Hi. Hi, everyone. Welcome to
Good morning.
second Hot Sits with Editors. Today, we have an honor of having Dr. David Chang as our faculty guest. Dr. David Chang is a professor of surgery, chief of plastic and reconstructive surgery, and director of Microsurgery Fellowship at University of Chicago. He has written many papers and published many papers on the topic of microsurgery, especially in lymphedema. And today we will be discussing the principle of microsurgery, how I do it, with Dr. Chang. Thank you, Dr. Chang, for having us.
Thank you so much. I am, can you allow me to share my screen?
Yeah, I think, Gary, can you have him as a host?
Yeah. First of all, thank you for inviting me. This is, hopefully we'll have fun. I was asked to talk about this topic and I kind of try to prepare a presentation kind of geared towards more younger plastic surgeons who are interested in microsurgery. So yeah, I cannot share my screen yet. Anyway, yeah, you have to make me you have to able.
I think I just did it. If you
Did you do it? Okay. All right, there we go. Here we go. Yeah. So you can see all that, right? Okay, good.
Yep.
Okay. Get all the pictures out of the way. So how I do microsurgery. So disclosure, this is, it's a personal bias for the most part. And it's my personal views, not necessarily that of the University of Chicago. So microsurgery, what is microsurgery? Microsurgery, it's a surgery. It's nothing magical or special. It's a surgery that we perform under a microscope. It is a very useful tool. It allows us to perform a lot of wonderful things like transplant tissues and connect and repair small structures. I think one of the important things in microsurgery is particularly for younger residents and surgeons, is that you need to know your equipments and instruments for microsurgery because these are important, and you should make sure that they're prepared and ready to go before you start the surgery. And this is old microscope, ceiling mounted that we used to use when I was at MD Anderson. I think they still have them. It's a good microscope, but it had interchangeable lens. A lot of the microscopes we have now have lenses that tend to be adjust. But if you have to know what kind of microscope you have, and you should know how to troubleshoot your microscope. So instead of relying on the nurses and scrubs, you should know how to do that yourself. Make sure they're working. You should know how the microscope, it can be adjusted, focus and zoom. I personally like to use a foot pedal. That way I can make adjustments without having to take my hands and eye off of the microscope. So I can continue to operate and make adjustments simultaneously. But I know others like to use hand control or the control on the monitor. The various different types of instruments and clamps and such. I prefer disposable clamps. These metal clamps that's been in the OR for a long time, unless they're adjusted, can have a very high pressure and can actually damage the vessel. So you need to understand what instruments you have and in advance and get it all prepared. Some of the things I personally like to use, I like to have a micro wipe to wipe the instruments, background. Everyone seems to use heparinization. They usually seem to use one in the syringe. I like to set it up so that I have a saline bag with the heparinization already in it, put a pressure bag around it, connect with the IV tubing, and then I have the little connection. And it's right next to us so that whenever we need it, we can just grab it and squirt the heparinization into the lumen as we're doing microsurgery. And it's better than trying to keep asking for the syringes back and forth. Setup is very important. I think those who have worked with me know that I like to have a nice clean field when I'm doing microsurgery. So this is a field where we do micro. I set up with moist slabs, 3 or 4 of them, and then and I say, it's like setting a plate for dinner, nice dining, and then I put some nice towels and then micro wipes for each of us, and then heparinizate in here. Then you don't have all the distractions and clutters around. So when you're doing a microsurgery, you kind of focus on the micro part. Positioning is important. You have to be comfortable. Just not yourself, but your assistant as well. So try to set up the microscope so that you are having a neutral gaze into the scope. You're not too flexed or hyperextended. Elbows about 90 degrees. I prefer to the micro standing rather than sitting, unless of course I'm doing reconstruction in the hand, like replant or raising a radial forearm flap. And you can see here, sometimes your 2 surgeons might have different height. So here he's taller than me, so you have to make sure you adjust it and that they both can operate comfortably. And I don't drape the microscope. I just put a towel around to adjust the intraocular distance, and then boom, you're ready to go. Once you set it up, there's no need to really move the microscope around. And here, this is a view of one of a former fellow. He looks somewhat uncomfortable sitting on the stool here. Looks like we're doing a LV bypass in the leg. So I like to use the foot to control my foot pedal to adjust. And you can wear the socks if you want. You don't have to wear the socks. Now, when we're doing a microscope, particularly in a deep hole like in axilla, it's helpful to kind of level the field. So I will build up the hole with a moist ray tack or a sponge to create a platform for a vessel to rest on. So to bring the vessel up to the field where you could operate easily. And try to line the vessels up so that the micro can be done easily by by you and your resident or fellow. Certainly, we should be able to do the micro in any direction, but especially if you're working with someone novice and trying to teach them, it's helpful to set it up so it is rather easy for them. When we are doing perforator flaps, like a DIP flap with long vascular pedicle, it's critical that you check to make sure the pedicle is not twisted and kinked. So once you're in the microscope, I cut the vessel. I will irrigate the lumen. That's the most critical part. And I'll examine the lumen to make sure there's no internal tear or anything like that. I irrigate the lumen, make sure there's no debris from the areas, no lint in there. Then I stitch. I don't clean the vessel that much or at all, actually. Most times I don't clean the vessel. I just cut it. I cut the vessel and I start suturing. If the edges look friable, I might trim the edges. But I think if you excessively clean the vessel, you can actually cause more damage to the vessel. Placement of suture is important. As you can see, I will talk about this a little bit later, but I do the back wall first and I walk it up. I do the back wall and then I walk it up. And it's important to take a full thickness bite of all 3 layers, intima, media, and adventitia, particularly when you're working with a very friable vessels, if they're radiated. If you take small bites, it's going to tear through. Take large bites, making sure that it allows the vessels to evert and create a seal so it doesn't leak. And the fewer sutures you can place, the better. The equal distance from vessel edge and from one another. So try to make all the sutures look almost identical to each other, making sure there's a good size match. And the fewer sutures you place, you have fewer holes, fewer trauma to the vessel, fewer foreign body. So less is more. And avoid extra needle holes, meaning that think before you put the needle in. Don't just put it in and go, oh, this was too small, this was too big, and pull it out and keep doing it over and over. Every time you do that, you're poking a hole in the intima. and introducing foreign bodies in there. So visualize where you want to put the vessel, put the needle in, and then put it in exactly where you want it to go. And one important thing is to use the curve of the needle. This is something I always emphasize. So at the end of the case, your needle shape should be exactly the same as it was when it came out of the package. If your needle looks like a letter J or I or number 3, then your technique was not good. You were forcing the needle to go in a direction that it was not designed to. Square knot. I think it's important to put square knots in. It is okay to cross hands. I know a lot of people say don't cross your hands, and I don't know why you cannot cross your hands. You can cross your hands, place square knots. If you do square knot, you only need like 2 knots actually a lot of times, 2 throws if there's no tension. Surgeon's knot, I generally don't use surgeon's knot, although if you need it, that's fine. I use a surgeon's knot when the vessels are in tension, and if I don't put surgeon's knot, the knots will become loose, but most times you don't need surgeon's knot. I use a needle holder to tie. I do the microsurgery same way I close the skin. So what I tell my residents and fellows is that when you're closing the skin and or closing anything and you're instrument tying, practice your technique when you're instrument tying. It's the same technique under the microscope. So everything that I do under the microscope is the same thing I do without microscope, just that I have a microscope in front of me. So I don't change my technique just because I'm on the microscope. I know a lot of surgeons all of a sudden start operating differently when they bring a microscope in, and I'm not so sure why. So I will do my micro just the way I do without micro, except I have a microscope. So I use a needle holder to take the needle out, using the curve of the needle and then the tie. But if you want to use forceps, that's fine. I think suture tension is critical. If you make it too tight, sometimes I see the fellows or residents tying it too tight. It causes a necrosis of the vessel. You can tear the vessel if it's friable. So you want it to be snug, but not overly too tight. Of course, if it's too loose, it's going to leak. So you got to make sure that the tension is critical. So we talked about this, visualize where you put. And use both hands. Use your left hand or right hand. If you're right-handed, of course, you'll be using your right hand to the micro. If you're left-handed, you may use your left hand. It doesn't really matter. But use your other hand to help you suture. So, hold the vessel, open up the lumen, create a counter tension. All those things are important. And I'm kind of known to be a fast surgeon, but you got to take your time, slow down. If you feel like you're rushing, then it's not good. You want to calm down, slow down, take your time, and do everything right the first time. The thing that slows you down is when you make a mistake. When you make a mistake, it sets you back quite a bit. Then you got to undo everything, and of course, it could lead to complication. So try to do everything the first time. So this is really old video. I apologize. This is probably like 2005 or something like that. Kind of demonstrating how I use my right hand. Actually, I think there's a fellow doing it, but same technique you can use. See, you just make a loop and then tie. This loop is a little big, and so I prefer to have a shorter tail and a smaller loop when I'm tying. So just like your instrument tying, it's no different. So cross the hand, make sure that it's a nice and snug. So here the back wall has already been done. Again, I'm sorry, I apologize for the quality here. And you just kind of press forward. As you don't see it here, but there's a little space there, and you should be able to see the needle go through the lumen across without hitting the back wall there. So just use your right hand to tie. But I know many people like to use your left hand to tie, and that's fine. So square the knot. And then what you also see is that I have a single clamps rather than ACMA. And here's the vein that was done. You make sure that the vein is flowing well. And you can see that this was old one because I didn't use a coupler. So here's double laparoscopy and chem. I think it's very useful if you are doing it by yourself and you don't have anybody helping. But for the most part, I prefer to have 2 single clamps. Here, the end-to-end versus end-to-side. Either way is fine. I prefer, if I have choice, I prefer end-to-end. I think it's easier. I prefer going to smaller vessels, branches, and go end-to-end. Interrupted versus running. I generally prefer interrupted, even for the vein. I know some people say, oh, you got to do running, otherwise it's going to leak. That's not true. And so I prefer interrupted. I think it's more precise. But I do running sometimes if the anastomosis is very large, especially if the end-to-side. And then back wall first. I always go to the back. I go away from it, then I start walking back up. This way, your lumen is always visualized. I don't have to turn the vessel over. So with a single clamps and using a back wall technique, I can do micro in almost any space. So most of the time, I don't take ribs out like in intramammaries when I'm doing breast, and I don't need a lot of space. I need a very small space, put clamps on it. I don't have to flip the vessel back and forth. And then I can also visualize the lumen the entire time. So I prefer the back wall technique, but different people have different preferences. That's fine. So coupler, I think, makes anastomosis much easier. Again, I was probably the last person to convert to couplers when it was introduced when I was at MD Anderson, and I hand-sewed everything out. But I eventually gave in, and now I do coupler almost always. But the important thing is that you find a technique that you feel that you like the best, that makes sense to you, and you're comfortable with. So, when I'm working with a fellow resident, I teach them my technique. But if they go and learn from other faculty and they prefer other technique or they hybrid, that's fine. So my technique has evolved, probably gradually over the years. So you need to find a technique that works best for you. So in summary, I prefer end-to-end if possible, but end-to-side is fine too. Prefer coupling, interrupted. And then, of course, the patency test, particularly to check the vein, do the milk test, make sure there's a blood coming out to the other side. Somebody asked about flap take back. If there's any question about the perfusion, you need to open up take a couple sutures and look at the anastomosis. So I have a very low threshold for looking at the anastomosis. If I'm deepithelializing a flap and I see the blood is not as quite good as I think it should be, then I take a look. Sometimes the vessels do go under spasm, but that's not that common. Occasionally it does. But so if you don't see the pedicle pulsating, then you need to take out a couple sutures and irrigate it, take a look, and repair it. Waste energy in surgery, yes. So the way to operate quickly is to minimize waste of energy, minimize making mistakes. If you are moving fast and then you create all kinds of problems, bleeding everywhere, and your flaps vessels are thrombosing, then you're going to end up taking a long time. So you got to eliminate all the messes, all the mistakes. And then if you look at your movements under the microscope, or even without microscope, if you are doing a lot of redundant, unnecessary maneuvers that's just wasteful and not contributing anything to what you're trying to achieve, you should eliminate them. So you need to critique your technique and make sure that you are being efficient with your movements. Okay. And I think another reason that people often operate slow is they're indecisive. Things have not been planned out. So you really need to think about scenarios in advance. And what would I do if this happens? What would I do if this happened? What is my plan B, plan C? And kind of think about all these things in advance so that when it does happen, hopefully it won't, that you are ready to move on to the next step immediately without being indecisive. So that comes from indecisiveness, I think, comes from poor planning and also from not understanding the anatomy and things like that. So you got to prepare yourself, then you can make decisions quickly and then move forward. Does speed matter? It's not a race. I think when young surgeons are looking at the clock, trying to do as fast as possible and always boast about how fast that they operate, I kind of find it a little bit funny because it is not a race. And you don't operate fast by operating fast. Moving fast does not translate to operating fast. Okay, you operate fast by being efficient and by being error-free. If you can operate efficiently and error-free, before you know it, your surgery will be done. But speed does matter to an extent. It does matter. Clamp time matters. If you have a clamp on a vessel for a long time, it can cause intimal damage. I think we've all seen that, where after you do osmosis, you find there's a intima has been separated where your clamp was on, and you got to resect back and redo it. So clamp time does matter because it causes intimal damage, and also ischemia time can matter. I mean, although it's been a long time since I don't really check my ischemia time. I know some surgeons will say ischemia time off, ischemia time on. But for the most part, if you are doing microsurgery on a regular basis, you should be able to get the flap perfused pretty quickly. But if it's taking you a long, long time and your ischemia time is like 6 hours, 5, or 4, 6 hours, then there's a problem there. And I do think the anesthesia time does matter. I think that if you, for example, if you can do D flap in 3 to 4 hours versus 10 to 12 hours, I think the patients who are on the table for a long, long time, their recovery is not as good, especially if they're elderly. So I think that getting them out of the OR table relatively quickly can be helpful. Recipient vessels, does the size matter? So there's some surgeons who advocate and say make micro to macro surgery. Well, I don't know. I think the quality is more important than the size. Bigger is not necessarily better in my mind. I think you have to put a lot more sutures there. There's more chance for intimal damage. Also, in patients with atherosclerosis, bigger vessels tend to be more diseased. So I prefer to, like for example, head and neck. I don't think I've ever gone to external carotid end to side. I will always find a branch that I can use. Or even when doing lower extremity surgery, I'll try to find a branch or that comes out. I find that to have less disease, and so I look for the vessels that are better. Better vessels better. So I look for the vessel, regardless of size. I look for the vessels that are better for the recipient vessel. I rarely use vein graft. Now there's some surgeons who use vein grafts very, very routinely, and that's fine. But I find that most of the time you do not need vein graft. I think I very rarely use vein graft. Sometimes I do use it when it's necessary. But somebody asked about syphilitic vein turn down for head and neck. I do use syphilitic vein turn down. I do that for like when I'm doing breast and the internal mammary vein is not available, maybe because it was a take back or something. Then I use syphilitic vein turn down. I have never used it for head and neck, but you could. There's so many other options in head and neck reconstruction. So a pipework transverse cervical vein or internal mammary vein, but you could definitely use syphilitic vein as well. Flap checks, clinic exam, gold standard. If the flap is external, whether it's skin or muscle, you can get a Doppler out there. If it's buried, use implantable Doppler. We do use an oxygen saturation monitor. In Chicago, I find it helpful because I can monitor the flap continuously and even on my cell phone. So we can always check, which could be annoying, but it's a good way to check, have a continuous monitoring. I do not give any routine anticoagulation. Somebody asked about that. I use heparinization to irrigate the lumen when I do micro, but after surgery, I don't put them on anything unless the vessel clotted. If it's a take back, then I might put them on a low dose heparin drip, maybe an aspirin, but I don't give anything. My patients just go to regular floor. They don't go to ICU unless they need to go there for a medical reason, like if they're on a ventilator or something, then they may go to ICU, but they just go to regular floor. So microsurgery is a surgery using under a microscope. What about supramicrosurgery? There's a lot to do. People talk about supramicrosurgery like something magical. What is supramicrosurgery? Supramicrosurgery is a surgery. It's a surgery that you do under a microscope, just like microsurgery, except they have to be very small. So less than 1 centimeter or so. So it's not, it's just smaller structures you're operating under microscope. Nothing special about it. And just like microsurgery, I think having the right type of equipment can make supramicrosurgery easier to do. So quality of microscope instruments. Now, because of the popularity of lymphatic surgery, a lot of new instruments and sutures have been developed for these tiny little vessels, and having these can make a difference. Because I've done them for many years without these, and it was more difficult back then. So, this is one of the microscopes that I use. We have a couple of these that really helps us to perform Supermicrosurgery. And then I also have all these instruments and sutures that are necessary. And here's a lymphovenous bypass here. And you can see that I am using a technique that I just talked about. I just use the right hand needle holder to tie. I use the back wall. This is a little, of course, this is a little fast forward, but you can see I just use 2 knots. They're just square knot, 2 knots. Pretty much that's all you need if there's no tension. And then just come forward. So same technique, whether I'm closing the skin or I am repairing a lymphatic vessel, for me, it's the same technique. I don't change. And so it's easy you can practice your micro. Here's a patency test. You can practice your Supermicrosurgery when you're closing the skin. It's the same technique, just translate on the microscope. Robots are great. I think I'm all for new technology and things that can make us do things better. Obviously, the main advantage is no tremor. But one thing is that I have tried robots. I used it when it first came out a long time ago, maybe 15, 16 years ago, because I was doing a lot of intrapelvic nerve repairs after radical prostatectomy. And then they would do on the robot. So then I would use a robot to repair the nerves. And the thing is that, of course, they're kind of clunky and you cannot really use 9 or 10-0. You have to use 6 or 7-0 because it will break. And there's loss of tactile feedback, which I think is important when you do microsurgery. So when I'm doing vessel repair, I can feel the vessel with the tip of the needle as I'm going through them. And all those tactile feedback is important for me as I'm doing the surgery, as I'm tying the knots, and you lose that. So if you're using robot for the first time, you will see that you are often bending the needle or you are breaking the suture. But I suppose with more experience, you will get better at it. And there's some robots that are made. This is one of them. There's another one that I have tried that are meant more for Supermicrosurgery. But I think for the most part, if any of the vessels are on the surface where standard microscope can be used, I think I don't see any advantage of using robots. But if you're doing micro in a deep hole, like in the thoracic or in the axilla, in the thoracic or in the pelvis where standard microscope cannot reach, I think the robots can be helpful. I do think that in the future, we'll have robots that will actually perform the osmosis for us. And we don't have to actually end up having to suture the vessels ourselves. So basic principles, keep it simple. Simplicity is the ultimate sophistication. So Leonardo da Vinci said that. And this sounds simple, but actually keeping things simple takes effort. It's not easy to keep things simple, right? Coming up with a simple solution to complex problems is challenging. So you got to really think about that. And doing less sounds simple, but also doing less is actually, it takes effort. You have to think about how can I achieve high success rate, good result, but by doing less. You have to think about these things. So keeping things simple and doing things less sounds like you're doing less, but actually it takes effort. It takes time. And then being efficient also takes effort. You have to practice in being efficient, but think about it and how can I become more efficient? And then with all these tools that you have, we should not be afraid to think out of the box. As long as you understand the basic principles, you should be able to come up with the solutions that fits your challenges at the time. And you should not be afraid to try things if you think it's going to be best for the patient. And the most importantly, I think you should have fun. Microsurgery is a lot of fun. You should have a good time in the OR, have fun with your colleagues. There should be no tension in the OR. It should be a good time, relax, fun, play music. And I think when you're relaxed, you operate better. Somebody asked the question about how do you deal with the challenging situations. I think you got to relax, you got to have fun, and then just and not get all tensed up. And there should be no tension in the OR. People should not be all tensed and nervous. Then I think that doesn't bode well for high quality. So you really need to have fun and be relaxed. So thank you. That's the end of my talk. So stop sharing.
Thank you, Dr. Chang, for a fantastic and inspiring talk. I know it's really great to, especially it's early in your time, and then have you come and talk to this young microsurgeons who are very, it's a rare time to talk to you. So I know you answered a lot of questions, but I'm gonna share, and then you have a lot of questions on the chat box as well. So first, we will start with the question from the audience. So start with that. Let me see if sorry, I think, see. So I know that, sorry, the Zoom is not letting me see some of the questions. I think I might just come out of this. Okay, so first, I'm going to just clump these questions because they're kind of questions about the basics of microsurgery. So first is Dr. JP Hong asking, how do you determine what number suture to use? And then another question, it was, do you do vein or artery osmosis first?
Okay. So, well, depending on size of vessel. Like breast, vessels are they're large, 2.0, 2.0. I use 9.0 nylon. If they're smaller than that, like 1 millimeter, 1.5 millimeter, then I go 10.0. The lymphatic surgery, if they're anywhere from 0.5 to 1, I use 11.0. If it's like 0.3, less than 0.5, I use 12.0. So, it's kind of all the visual thing, but that's kind of kind of a general guideline. And when I'm doing a flap, I generally do vein first. I do the vein first, and then I do artery. Not always. Like, for example, when I'm doing a lymph node transplant, like supraclavicular, and I cannot really find a good vein, they're very tiny, then I might do the artery first, and I see where the vein, which vein is flowing. Then I will hook it up. But if I'm doing, like, say, for most any other flaps, I do vein first and I do artery. That way I don't have like flap that has the arterial flow going in when I'm trying to do the vein, and the flap is engorged and oozing out everywhere. All with the coupler there, it's only a few minutes. It doesn't take very long. But so yeah.
Great. And then another question is, it says, thank you for a great lecture. In end to side and osmosis, how do you do your arteriotomy, and which angle do you prefer of the best flap vessel going into the recipient vessel?
Yeah, so on the end to side of the artery, I use a punch, but the punch can be, at least ones we have are smallest I can get is like 2.0, 2.5 millimeter the cardiac surgeons use. So if the that's why I would prefer to find the side branch. If the pedicle is smaller than that, I prefer to find a side branch so I can connect to the side branch. And it's okay to have a smaller one. Having a smaller recipient artery going to the bigger artery is fine. So I prefer that, but I use a punch. That way the edges are nice and clean. You can do. I know, like some of my colleagues. One of my colleagues likes to go to large veins end to side, and he will use the scissors to cut like little window out. But I don't do that. But I use punch. And the angle, I just go 90 degrees. Depends on where the pedicle is coming from. I'll just go 90 degrees. I don't think it makes any difference. But I'll try to look for a branch somewhere and then go into that.
What about the lymphatic surgery? Do you do end to side for those, or
I do? Yeah, I do end to side the same way. So, like, if I have a vein that is larger than the lymphatic by a lot, or has a huge, I do a load test first. If it has a huge backflow, so I don't go, I will not go end to vein if there's a lot of flow. So if I find it, then I go into side. Then I use for that I use scissors, Supermicro scissors. Just cut it, just cut it, and then put the lymphatic in there, and then they're so small. I don't know what angles they make. You probably go in 90 degrees. They're tiny. So
Right,
it doesn't
right.
matter. Yeah.
I was watching
Yeah.
your video and I was like, look how fast he is.
That was in a slow motion.
I know you mentioned, I know there was a question about the anticoagulation. Another question is if there's a flap thrombosis and that you're doing
Yeah.
re-exploration and you salvage the flap, what is your anti-thrombotic protocol?
If there's so if let's say I'm doing micro and I find that during the surgery, say artery go, it's artery is going to go down, not the vein usually. If artery clots, then I'll open the clot, and if it's right there, I will ask anesthesia to give a 3,000 unit bolus heparin one time, and that's it. Because I suspect that it clotted because we did something wrong. We made a mistake, or maybe something got into the lumen, maybe like a lint or a clot or something. If it's a take back, the patient comes back to the OR, then and there's a thrombosis. I'll take the clot out. I'll ask them to give like 5,000 bolus heparin, and then I'll do the repair. If it looks like it's a repeat, if it seems like if I have to, if after I do that, if it happens again, then I will then put my like heparinization drip, 500 units an hour. I don't monitor PT, just low dose. So that's what I typically do. Yeah.
And there's a controversy of how long you let that 500 units per hour go. How long do you keep?
Yeah, it takes about five days or so for industrialization of the happen. So I do at minimum. So I do about 7 days to ensure that when I stop heparin, that the endothelium has already healed across the osmosis. So I do for 7 days.
Okay.
Yeah.
And another question they have is, what do you do for vasospasmic vessels? Some microsurgeons prefer lidocaine, papaverine, different kinds.
I like papaverine and patience. So you put papaverine, you put a lap over it, you walk out. Don't sit there and keep looking at it. Some people get very impatient, keep looking at it. I put a lap over it, then I just walk out. I just say, I'll be back in 10, 15 minutes. Just go have a coffee or something, and then come back and take a look. Then usually it's okay. I think spasm happens a lot, I think, because we over dissect the vessel, and people are playing around with the things too much. So, but when you're doing a small vessel, certain vessels do spasm a little more. We do know that. So I just put papaverine, and then I guess if you don't have papaverine, you can use lidocaine 2%. But we have it, so that's what I use.
Right, that's what I use for papaverine as well.
Yeah.
And then another question is, how do you preoperatively evaluate artery and recipient site? I think it's mostly a question about the head and neck, whether you get like CTA or.
No, I don't do any imagings for anywhere in the body. I expect that if patients are alive, they're gonna have arteries and veins. So no, I think we can always find something.
Right,
I don't typically do CTA or for abdomen, but if it helps you do the surgery better, go ahead. That's I have no objection.
Right. And
yeah, I mean, of course, only other time I would maybe get an angio is like if it's an MBA trauma to lower extremity, and you want to make sure that you got 3 vessel runoff. Those I will do that, but other than that, I won't do. Yeah. Right.
And the question they have is, what is I'm assuming, what's the maximal ischemia time that you would allow before you?
Well, depending on the tissue, right? All the different tissues have different ischemia time tolerance. So if I'm doing a free jejunum, you don't have a lot of time. You cannot, but or muscle is a little bit less. But if you're doing a fibula or bone, I mean, it could be a quite a long time. So I think depending on what you're transplanting. So depending on the tissue, if you have skin flap, you can tolerate a bit more. Like say, if I'm doing a bilateral SCAF flap, I can harvest and put them in the back table and do one side, and I'm okay having it just sitting there for a while. But if I'm doing jejunum or something, then I need to make sure it gets perfused pretty quickly.
Right. And let's see, there's a lot of questions. I'm kind of trying to clump them together. So I think it's just a general question. Which loop magnification would you recommend for junior plastic surgery residents?
Which
or
what?
even faculty? Loop, like what size loop magnification?
Oh, yeah. So I think most of my resident fellows have 3.5. I use 2.5. I started 2.5 when I was a long time ago, and I just became used. I do have different sizes, but I use 2.5. It just gives me a wide field, and and I do all my micro on the microscope. So there are those who do micro with loops. Then I think you need the higher mag, maybe 3.5 or 4.5. But so I use 2.5. So if you're starting out, I would start with 2.5, and then once you get comfortable, you can move up. But I have 6, but I don't like it.
Right.
So yeah.
And then another question is, what do you do? Like, what are your tips and tricks for ergonomics of microsurgery, like long case? I think you kind of touched
So
on
I have an entire talk on that, because I personally, JP knows this. I personally had some issues leading to that. Again, I think position is very important. I think standing is better than it's been shown that standing is better than sitting for your spine. So I prefer to stand, move around. I know those people. There's some people will put like a time clock, and then every 20 minutes or so take a little break. But just move around a lot, and take breaks. If you're tired, take a break, and it's okay to take a break, and then just make sure that when you're under the microscope, it's not that bad. It's under the loop, and you're looking down and raising a flap. That's what's really bad for your spine. Under the microscope, you can adjust your head so you're not really looking down or anything. But especially if you're like assisting, and if your faculty puts you in a really awkward position and you cannot say anything, then but you should be able to say, hey, can we adjust the. So if you are the leading surgeon, just be mindful of your assistant. Make sure they're comfortable, just like as you are, so that you all can be comfortable. It doesn't do any good if you're comfortable, everybody else is suffering, so you have to just kind of pay attention. Yeah.
Right. And then especially if they're if you're teaching residents, and then residents are doing micro, it's best to have them at the most comfortable position as possible. So just like you say, you minimize any errors for them as well. So I have on the PowerPoint, I think I'm just gonna ask questions out of the PowerPoint. I have a slew of question of lymphedema as your specialty. So first question is, how many years of practice do I need to do before I could do a lymphatic surgery?
Well, I don't think it is a number of years. So as we all know, when we are training resident or fellows, there are some who even right from the beginning are very comfortable under the microscope. They just have natural gift for it. They don't need years. I mean, they could probably do lymphatic right away. And so I think some of it is a natural ability that you may have, but certainly more you do, the better you get at it, obviously. So I don't know if it's in terms of years or weeks or how intense it is. If you already have a natural gift and are pretty good at microsurgery, just a little bit of practice, I think you can do it. So I don't think it's terms of years. I think it's, but practicing regularly is a good thing. If you're only doing it every now and then, it's like anything else. If you only do it once in a while, then you kind of start all over every time. So it's if you're going to be doing lymphatic surgery once or twice a year, you're not going to get very good at it so you got to do them all the time.
Right. And this question is, how do you decide on a workup for primary lymphedema patients? What are your kind of algorithm to determine?
For primary lymphedema?
Right.
Yeah. So if a patient shows up and has a swollen arm or leg without any kind of special cause, I give lymphoscintigraphy, make sure that if lymphoscintigraphy is normal, then the lymphatic function is probably okay. So then, you got to then also examine clinically, like for lower leg. A lot of times they have venous issues, venous stasis and things like that. You got to make sure you rule that out. But if it's a young person who shows up, they're like, early 30s or even 20s, and their leg is swollen. They say, "Oh, it's been like this for a while. It's probably lymphedema." Then I get lymphoscintigraphy, and then make sure the function's okay, and then make sure there's no other reason that they have the swelling. So, but I think the lymphoscintigraphy is important.
And then another question is, how do you select patients for prophylactic LVBA or lymphovenous transfer? Lymph node transfer after mastectomy.
Yeah, so we don't do prophylactic lymph node transplant. We do perform prophylactic LVA as a part of the study. So I know that area still, to me, it hasn't sorted out. So I don't know, actually, prophylactic LV lymphovenous bypass would be something would be found to be useful or not. We don't know yet. I think some of the data are very preliminary still. So we do it as a part of a study. The patients are picked by our breast surgeons. If they think that the patient's going to be getting an external dissection, then we'll put them on the list. So we don't know whether they're going to do it or not. And then as they're doing the external dissection and inject a blue dye, if they see that the arm is all draining into his nodes, and they will call us and we'll come and do the lymphovenous bypass surgery. So they will, but if they, even if they're doing a sentinel node, if they see that that's the only nodes that the arm is draining into, sometimes they'll call us and we'll come and connect them. So they will let us know. So we're kind of on standby, and then we run in there and we just do it. I don't do lymph node transplant in a patient with active breast cancer or who are being treated. We just don't know what's going to happen with that. So I usually hold off on that. So that's our protocol for lymphovenous bypass.
And for those bypasses, I'm sure, sometimes you find good veins available, or sometimes your lymphatics are well preserved by your colleagues. What are your tricks to let them know so you have the best success?
Yeah, so our breast surgeon is actually very good about, so they will show us, they clip the lymphatic, and if there's a blue dye in there, they engorged, and you can see pretty easily. And then you got to find the veins. So there are a lot of veins in the axilla. So you can get one of the branches out pretty long, and once if there's no huge backflow, you can go end to end. Most times I can go end to end to some vein. They tend to be a little bit larger than lymphatics, and maybe there are multiple lymphatics. So I just intubate them into a vein. If I cannot find one that has good, that has minimal backflow, then I might go intraside. But it can be challenging because the length of the lymphatic can be pretty short. So it's good to have one that, and I just get a vein that you can reach all the way to lymphatic. And there are a lot of branches there, so it's not really that challenging.
And then whenever you do bypass, just for any kind, not the prophylactic, but when you do bypass, do you use ICG and blue dye? Do you use? I know Dr. Hong uses ultrasound to find lymphatic and vein. What's your algorithm for those?
When I'm doing LV bypass? Yeah. So I don't have experience with ultrasound, so I probably wouldn't know what to do with it. So I use ICGN. I use ICGN to map out, and then I do use isosulfan blue. I inject them in the same site where I injected ICGN, so they follow the path. But the blue dye doesn't always give to lymphatics, but when it does, it just makes it easier. So that's what I do.
And then just one last question about the lymph node lymphedema. Obviously, you popularized the supraclavicular lymph node transfers, and is that your go-to for every case, or? No.
So if I need a free flap as a lymph node transplant, so we should call these transplants, not transfers. They're transplants. Dr. Bunke used to be adamant about that. He didn't like the term free flap, or he said these are tissue transplants. So if I need a free tissue transplant as a lymph node transplant, then I go supraclavicular, like for lower extremity. For the upper arm, in patients where they had breast cancer related lymphedema, and if their back looks good, I will use the lateral thoracic. It's right there, it's easy. and I will have to the micro. So I will do that. Or if they need breast reconstruction at the same time, then I'll use, I'll do a deep with the lymph node transplant. That's the only time I use groin is if I'm doing a deep, and I can take them together.
And do you get,
for the supraclavicular lymph node transplant, I would use it for most of my leg lymphedema where I need to transplant down to the groin or the ankle or to the calf area.
and for the deep and then the groin lymph nodes, you get spec CT to determine, or you just?
No, I use reverse mapping. I inject technetium-99 and then I use gamma probe to find a sentinel node. And then I'll stay away from that. And then I will follow the circumflex from externally and medially. And I do not go beyond the SIEV, SIEA area. And so, I use gamma probe. It's very helpful. We just did it yesterday or the day before. So I just gamma probe and then take the nodes along the circumflex area.
And then do you angle the flap so that the node side goes to the axilla?
Yeah. So typically when I'm doing a breast, I use a contralateral flap and put vertically. But when I'm doing with the for lymph nodes, I go ipsilateral. So that the when I put it vertically up, the lymph nodes are going into the axilla, and then the pedicle for the deep has to be flipped, kind of against its natural position. But so we had like Singapore failure, so it wasn't a problem. So then I just flip the vessel. Then I will just do the breast reconstruction first. I will do the whole breast reconstruction, the epithelial. I do everything inside it, and then I often will make a counter incision in the axilla. There's usually a scar there anyway from a previous surgery, and then I will connect the vein and all that in the axilla separate after the breast is done.
Right.
That way I don't have to manipulate worrying that I'm going to tear the vessel anastomosis apart.
And I'm going to go back to the Q&A on the chat box. So Dr. Hong is asking, what is a good model to get started with microsurgery?
Yeah, I think if you want something more, I mean, you could practice for those residents or students. You can get like a plastic over and put rubber band and make some slits, and then you can practice the loops at home doing that. There are kits they sell. I don't think you need a kit. You can just make it yourself. Just put a glove over like a plastic container and put rubber band around it, make it nice and taut. You can make a bunch of slits and then practice. If you want something more living, just get chicken thighs. Got a lot of nice vessels. They're good vessels, easy to see. So practice on them, and then you can have for your dinner. So I think chicken models are good, but I don't think you need to purchase anything fancy. You can get a lot of things you can practice on.
And then another question from the group is that how can I establish microsurgery practice in a new plastic surgery department? Well,
depending on where you're practicing. I don't know what country this question is coming from, but in the United States, obviously you're going to need the support from your leadership. That's what they want to do, and if they're not going to get you the proper resources, then it's going to be tough. So, but if you are the only person, and if you can determine whatever you can get, obviously you need to feel comfortable doing microsurgery. And I don't know what kind of help you'll have, but you need to make sure you have adequate resources. It's not just the microscope and instruments. You got to have the whole team, right? You got to have the nursing team, not only in the OR, but on the floor, who can monitor the flaps for you and things like that. It's not like you're going to be sitting next to a patient all day yourself to look at the flaps. So you got to make sure somebody can monitor. So you got to have a whole team. So you need to have support from the institution or the leadership so that you could do this and have a high success rate. Just doing a micro and having failures or complications is not it doesn't bode well.
we're reaching to the end of the hour. The question, I think it ends nicely, is that what are the future skills do you think the microsurgeon need to master?
Well, I mean,
Like,
if we are,
in addition to supermicrosurgery, what's the
yeah.
next?
Well, I think if we are gearing more and more towards doing robotic surgery and things like that, where we're doing things remotely, I think a lot of our young generation already have good skills doing that, right? Doing the computer games and things like that. So people who are good at doing those laparoscopy things or doing operating without tactile feedback, I think our younger generations are already very good at it. So I think that's probably I will see it maybe happening in the future.
So all the games that we played is okay. It was useful at the end.
Yeah, I guess. Yeah.
All right. Thank you very much for taking
Thank
your
you.
time busy out of your schedule. I know that Gary wanted to take a photo. So it'd be great if everyone could turn on your camera. So, you know, we could commemorate the time that we. And thank you very much for, I mean, it's just really hard to, you know, get a time with microsurgery giants and, you know, just kind of pick and, you know, talk about all the things that you do to make successful microsurgery. So thank you so much. And I think if everyone could turn on the camera, that'd be fantastic. And then obviously it's so early in some places. So I understand that, you know, if you are not inclined to turn on your camera. All right. Dr. Hong is not turning on his camera. Okay.
Everybody's all right.
Carrie, I think you're muted.
Who? JP?
No, Cody, the other social media editor, I think she wants to take a photo. So I think what I'll do is that I'll count for you, Cody, so you could take a photo. So, okay, on 3, okay. Okay, everyone, with the V, that's what she wants, I think. All right, thank you. Well, thank you so much for everyone to joining us. And thank you, Dr. Chang, for a really fantastic and inspiring lecture. Thank you.
Thank you for organizing.